Attendees are in listen-only mode.
Well, hello, everyone. This is Gidiz Barkan. I'm the president of the American Society of Cytopathology, and welcome to our educational sessions. This is the second session of the year, and we have the incredible pleasure of having Dr. Ed Cibas with us today. He's going to be giving us the part 2 of the thyroid lectures. I'll start with a brief introduction, which of course we know Dr. Cibas doesn't need an introduction to a cytology world. He is very well known and very well loved, but hear me out. Dr. Cibas is a professor of pathology at the Harvard Medical School and the director of cytology at the Brigham and Women's Hospital in Boston. He is the co-author of the book, Cytology, Diagnostic Principles and Clinical Correlates. Lovely book, now in its 5th edition. He's also the co-editor of the Bethesda System for reporting thyroid cytopathology. Dr. Cibas was the president of the American Society of Cytopathology in 2016-17, and he has won the award, the Lifetime Achievement Award of the Papa Nicola Society of Cytopathology in 2019, and in 2020 he received the Papa Nicola Award, the highest award given by the American Society of Cytopathology. It's going to be a delight to listen to him with the thyroid part 2. And as in the previous session, if you can write your questions under the questions part, I'll be happy to ask those questions to him as much as we can. He'll answer them. And if there's no time, we can always get back to you with the written questions. So listen on, and here's Dr. Cibas for you.
Thank you very much, Belize, and welcome everybody. Let's go ahead and just jump in. So for those of you who were here last Wednesday, we talked about 3 of the 6 Bethesda System categories, and I'm going to just briefly review them. We covered the non-diagnostic or unsatisfactory category. There's an example of a cyst fluid here with nothing but macrophages, and we talked about the requirement for at least 6 groups of well-visualized follicular cells, and each group having at least 10 cells per group. We talked about 3 exceptions to that requirement, but I will not go over those again today. We also talked about the benign category, and the most significant, the largest subcategory of the benign category is the benign follicular nodule. We defined a macrofollicle as typically a flat sheet, which can be either large or small, that's comprised of evenly spaced, benign appearing thyroid follicular cells that are showing good social distancing. The nuclei are round, they have a characteristic granular chromatin texture, and they can have small to medium-sized nucleoli. And a benign follicular nodule typically is sparsely to maybe moderately cellular and has abundant colloid. The colloid comes in 2 types. It can be either hard colloid or watery colloid. And on liquid-based preparations, the watery colloid has the appearance of translucent folded tissue paper as seen in these 2 images on the left. This, I think, is easily distinguished from blood. A blood clot, shown here in the upper right, typically has a thread-like appearance, which is fibrin. And the clot often also has scattered and trapped white blood cells like neutrophils, some lymphocytes, and even bare nuclei of thyroid follicular cells. But blood can also look like lysed red blood cells, shown here in the lower right-hand corner. This cloud-like granular precipitate is what lysed red blood cells look like on a liquid-based preparation. And I do think that these 2 different appearances of blood are easily distinguished from watery colloid on liquid-based preparations. And then we covered the suspicious for follicular neoplasm or follicular neoplasm category. I reminded you that these are synonyms, and the laboratory is encouraged to choose the term which they prefer and use it exclusively for that category in their laboratory. This is defined as at least a moderately cellular sample in which most of the follicular cells show an altered architecture typically described as microfollicular or trabecular, as shown in these images. We defined microfollicles as being aggregates of follicular cells that are crowded and show significant overlapping, not very good social distancing at all. There's typically scant colloid, and a subset of this category may have mild nuclear changes of papillary thyroid carcinoma, as shown in this case here. And if they have these mild nuclear changes, you might consider adding what's called a NIFT-P note to those cases. And I'll show you an example of that in just a couple of minutes. So here in the lower right-hand image is an example, a high magnification of a predominantly microfollicular patterned specimen that showed focal nuclear changes reminiscent of papillary thyroid carcinoma. If these changes are mild, it's perfectly okay to still place that case in the suspicious for follicular neoplasm or follicular neoplasm category. And finally, we talked about the Hürthle cell neoplasm or suspicious for Hürthle cell neoplasm. Again, these samples should be at least moderately cellular. You don't use this category for sparsely cellular specimens. Here, however, the sample has to be exclusively Hürthle cells or virtually exclusively Hürthle cells. A combination of Hürthle cells and macrofollicles is just a benign follicular nodule. And the Hürthle cells can sometimes be as much as 50, 60, 70% of the specimen. But so long as a substantial proportion of the sample is macrofollicular, that's a benign nodule. It's really a Hürthle cell neoplasm when the entire specimen is essentially all Hürthle cells. The differential diagnosis here includes, perhaps most importantly, medullary carcinoma. We'll talk about that in just a few minutes. I showed you an example of a parathyroid neoplasm that had oncocytic features last Wednesday, but there the clinical history was very helpful. The patient had hyperparathyroidism, so we were able to do immunohistochemistry for PTH and prove that it was a parathyroid neoplasm. You might also consider things like oncocytic variants of papillary thyroid carcinoma, and I'll show you an example of that and explain how we distinguish that from a Hürthle cell neoplasm. The management here is lobectomy or molecular testing. So today we'll discuss the remaining three categories, and I'm actually going to go backwards. We're going to start with the malignant category. And of course, we're going to start with papillary thyroid carcinoma, which is by far the most common malignant tumor that we see in the thyroid. Roughly 85 to 90% of thyroid cancers are papillary thyroid carcinoma. So here on this slide, I've put side by side an image of a benign follicular nodule on the left with an image of a papillary thyroid carcinoma on the right. I'd like to emphasize that the nuclear changes are probably the most significant findings that we look for to make a diagnosis of papillary thyroid carcinoma. And I hope you can see that almost immediately in this side-by-side image taken with the same magnification. So yes, the papillary carcinoma nuclei are usually larger than normal follicular cell nuclei, although that's not always an easy thing to appreciate. Perhaps more importantly, as we all know, it's the chromatin texture change, which is so essential to the diagnosis of papillary thyroid carcinoma. Here, I think you can see very nicely that the chromatin is much more finely dispersed, much more powdery, much more pale in the papillary carcinoma than it is in the benign follicular nodule. You'll also notice that there is nuclear membrane irregularity. You do have some unusual shapes of the nuclei, and you have some pretty obvious nuclear grooves. In addition to the powdery chromatin and the grooves, you will also often, but not always, see pseudo-inclusions. And here's a nice example of a pseudo-inclusion. These are not true inclusions. These are invaginations of cytoplasm into the nucleus. The hallmark of a good, reliable pseudo-inclusion is its large size. Generally, you'd like it to be at least a third or a half the diameter of the nucleus, and it should be well circumscribed. It should be punched out because it is actually lined by a nuclear membrane. Finally, it should have the color and texture of the adjacent cytoplasm. If it's just a small white circle, it might be an artifact and therefore is not quite so reliable. Again, nuclei are not terribly helpful. They might be small or medium-sized or occasionally rather large, but they are often visible. And unlike a flat sheet in a macrofollicle, these cells are not nearly as spread apart. They are much more closely opposed, and you'll see in this image how many of these nuclei are actually touching each other. Not acceptable social behavior whatsoever. So again, this loss of architectural good behavior is a sign of neoplastic growth in this papillary thyroid carcinoma. And I wanted to share with you this lovely image from a paper that was published about 16 years ago from the Italian group. They reconstructed in 3 dimensions the shape of classical papillary thyroid carcinoma nuclei using confocal microscopy. And it's remarkable how incredibly convoluted the nuclei are in a classic papillary thyroid carcinoma. Just spectacular. And the 2-dimensional images that we look at a glass slide almost don't do justice to this bizarre misshapen morphology. These look, to my eye, like modern sculpture. You might think of somebody like Henry Moore or Jean Arp when you look at these images. Just a remarkable change in the nuclear cytoskeleton in papillary thyroid carcinoma. As far as the architecture goes, they're often in flat sheets, and these usually represent the lining of a papilla that's been lifted away from the fibrovascular core, separated away from it, and now lying separately from it as a relatively flat sheet. You will sometimes see true papillae, and let's be careful to use the word papilla correctly in pathology. This is a structure that has a visible fibrovascular core, as you can see in this image. But some papillary thyroid carcinomas are predominantly, if not exclusively, arranged in microfollicles. Here on the top image is a high magnification of a follicular variant of papillary thyroid carcinoma to contrast with an FNA from a follicular adenoma. Very similar architecture, predominantly microfollicular. The only difference here is the chromatin texture. Notice in the PTC that the chromatin is finely textured as compared to the granular quality of the follicular adenoma. The cytoplasm is highly variable in papillary thyroid carcinomas, and I think it's actually more of a distraction than it is really helpful. It can be scant, or it can be abundant. It can be squamoid, as you see in this image. It can be Hürthle-like, or it can be vacuolated. And as I said, I think it's more of a distraction sometimes than it really is helpful. But good to remember that this variable morphology in the cytoplasm is not unusual for papillary thyroid carcinomas. Certainly, at least focally, many papillary thyroid carcinomas have a variety of appearances in the cytoplasm. Finally, many, if not all, FNAs from PTCs will show some homobodies, which I'm sure you're all familiar with. And some PTCs are partially cystic and will have lots of macrophages, and many of them include multinucleated giant cells, as seen here. These giant cells are not tumor giant cells. These are host response macrophages. These stain with macrophage markers like CD68 and PU.1, and they are negative for thyroglobulin and TTF1. So here again is this list of features that we associate with papillary thyroid carcinoma. I've taken the liberty in this image to highlight what I think most experts would agree are probably the most important criteria. powdery chromatin, pseudo-inclusions, membrane irregularity, nuclear crowding and molding, papillae, and sonoma bodies. Again, here's that side-by-side image, and it allows me to make perhaps one important observation, and that is you really should avoid making a diagnosis of papillary carcinoma on just a single criterion. The diagnosis of a malignancy here is based on a multiplicity of criteria, not just a single feature, but I can't tell you how many criteria you have to have. I'm often asked that question, and sadly, there is no answer. There's just too much variability in the way we prepare our slides, the way we stain them, whether it's with the Papinicolau stain or H&E or with the Wright-Giemso type stain, whether it's a liquid-based preparation or a smear. And there's such variability in our papillary thyroid carcinomas as well that it's very hard to make generalizations about what's required for a malignant diagnosis. Having said that, though, I will say one thing later on in this presentation, which is a recommendation for making a malignant diagnosis. So hold that thought for just a few minutes. Now, I do want to show you this list of the WHO variants of papillary carcinoma, just to remind you all how variable PTCs are. There's the classic or conventional type, the follicular variant, diffuse sclerosing, tall cell, columnar cell, cribriform morular, hobnail, solid trabecular, oncocytic, clear cell, Wörthen-like. I read these to you just to reinforce the histologic variability, which is then, of course, reflected in our cytologic specimens. Now, I could spend an hour talking about and illustrating just papillary thyroid carcinoma, and sadly, we don't have time to do that today. But what I can give you is just a taste for how variable this tumor really is. So let me start by showing you this example. This is a case I saw in consultation about 5 years ago, which is a at least moderately cellular sample. It looks like it's predominantly microfollicular and trabecular. You can see some small microfollicles, even with a little drop of colloid here, but also a tremendous amount of ribbon-like or trabecular architecture, a lot of crowding of the cells. If you look at the nuclei, they look mostly round, and to my eye, they had, what I thought was a pretty granular chromatin texture. So I called it suspicious for a follicular neoplasm. But this underwent a lobectomy at the Mayo Clinic, where it was signed out as a follicular variant of PTC. And it just goes to show you how very subtle the nuclear features of the follicular variant of PTC can be. You just don't see quite the wide spectrum of nuclear changes in a follicular variant as you do in the classic variant of papillary thyroid carcinoma. Here's another example. When you first look at this image, you may not immediately think of a papillary thyroid carcinoma. Your eye might be struck by the abundance of diffusely granular cytoplasm, and so you might imagine that this is a Hürthle cell neoplasm. But then, of course, if you look again, you'll notice that many of these nuclei have pseudo-inclusions. Some of them have multiple pseudo-inclusions. You simply don't see pseudo-inclusions as a rule in Hürthle cell neoplasms. These inclusions trump the cytoplasm, and this turned out to be a tall cell variant of papillary thyroid carcinoma. And a clue to that might be in this one cell here at the bottom in particular, which has this very tall cytoplasm. But then again, if you look carefully at the others, you'll begin to appreciate a bit of a tall appearance in others as well. Here's another case which may not make you think immediately of papillary thyroid carcinoma, perhaps because these nuclei just look so dark, but that's actually deceptive because these cells are very tightly crowded together. They have a very high nuclear to cytoplasmic ratio. Where they spread out flat, you can begin to appreciate that, yes, they do have nuclear features of PTC. There is some suggestion of pallor, there is molding, there is irregularity of these nuclei, and this is an example of a columnar cell variant of PTC. And you'd have to focus up and down very carefully through this three-dimensional group to find some intranuclear inclusions. Another example of a case that might make you think at first of a Hürthle cell neoplasm, but this is an example of the oncocytic variant of PTC. Again, here what's very helpful is finding these beautiful intranuclear pseudo-inclusions that are diagnostic of papillary thyroid carcinoma. So here again is our summary of the criteria for PTC. And I won't go over them again. But I do want to say perhaps one last word about the follicular variant of PTC. And I think as many, if not all of you know, the non-invasive form of the follicular variant of PTC has been renamed NIFT-P. We did that, well, not we, I didn't do that, but as a community, endocrine pathologists did this because it was discovered that these non-invasive variants of follicular variant of PTC can be treated successfully with just a lobectomy. Total thyroidectomy is not needed, and neither is radioiodine. But you have to use very strict histopathologic criteria to make a diagnosis of NIFT-P. You cannot make this diagnosis definitively on a cytology specimen. This requires extensive sampling of the nodule, encapsulation or clear demarcation. There can be no papillae. There have to be nuclear features of PTC, but there cannot be any psammoma bodies, any infiltration, any necrosis, or any mitoses. And there should be no special features of papillary thyroid carcinoma. I think you can appreciate from this list of very strict criteria that this is not something that we can diagnose with tremendous accurately on a fine needle aspiration specimen. We may be able to suggest the possibility of a follicular variant of PTC or NIFT-P, but we can't make a definitive diagnosis of NIFT-P. And that caused a lot of consternation when NIFT-P was the new name for this follicular variant of PTC because the word carcinoma was taken out of it. And people began to wonder, well, how can we ever call anything malignant on cytology, again, if we can't exclude papillary thyroid carcinoma? Well, there are some features that will allow you to exclude a NIFT-P. And one of them is finding true papillae. So if you have true papillae on your FNA, you know it's not going to be a NIFT-P. If you have psammoma bodies, you know it's not going to be a NIFT-P. If you have necrosis, you know it's not going to be a NIFT-P. If you have special features, like tall cell features, it's not going to be a NIFT-P. And if you have lots of internuclear pseudo-inclusions, it's very unlikely to be a NIFT-P. So in the revision of the Bethesda system, we recommended that you limit the use of the malignant category to cases that had these diagnostic features of a classical or other variant of PTC, not a follicular variant or NIFT-P. So sadly, we have to wave goodbye now to papillary thyroid carcinoma and talk about some other malignancies that we will see on thyroid FNA. And the next one I want to talk about is medullary thyroid carcinoma. Now, these look very different from papillary thyroid carcinoma, mainly because most of the cells, or many of the cells, typically appear as isolated, non-cohesive cells, single cells. Now, you will get clusters, small clusters, even some large aggregates. But when you look at the sample on low power, your eye is usually struck by a preponderance of isolated or single cells. Now, these cells are very variable in shape. And this is one of the things that makes this tumor a little bit challenging to recognize, because they don't all have just one classic appearance. So in this image, I'm showing you a medullary carcinoma that has what you might call an epithelioid and a plasmacytoid appearance. Notice that the nuclei in many of these cells are eccentrically placed, giving them a somewhat plasmacytoid appearance, although there's no perinuclear HOF. But others can look very spindle-shaped, and I'll show you an example of that in a couple of slides. Now, the nuclei can be round or elongated or very spindly in appearance, but they have typically a salt and pepper, classically neuroendocrine chromatin pattern, which I'm showing you here on this high magnification image. This is what we typically call a salt and pepper chromatin pattern. It's somewhere in between the more heavily granular appearance of normal follicular cells and the very finely textured chromatin of a papillary thyroid carcinoma. Now, typically, the nucleoli are inconspicuous in medullary thyroid carcinoma, although there are exceptions to that. And very importantly, you can see pseudo-inclusions in about half of the cases of medullary thyroid carcinoma. And here's a beautiful example of a couple of pseudo-inclusions that look exactly like what you typically see in a papillary thyroid carcinoma, except these cells are single cells and not arranged in the classic aggregates or flat sheets that we associate with PTC. Multiple nuclei, binucleation, multinucleation is very common in medullary thyroid carcinoma, as you can see in this particular image here. And if you're using Romanowski type stains to prepare your smears, about half of medullary carcinomas will have this beautiful red cytoplasmic granular appearance. And this can be a useful distinction between a medullary carcinoma and a Hürthle cell neoplasm, because with Romanowski stains, Hürthle cell neoplasms have bluish green granules, whereas medullary carcinomas, as shown here, have these beautiful pink or red granules. Amyloid is frequently seen, although not always, with FNAs from medullary thyroid carcinoma. And if you look in this image, you will find these little pale blue blobs of amyloid. Sometimes these amyloid fragments can be much larger than what you're seeing here. I will tell you that I personally, I don't think I can distinguish colloid from amyloid. I know that this is amyloid in this image because I know that this is a medullary thyroid carcinoma, but I don't think I have any magic answer for you on how you would distinguish colloid from amyloid, except to say that if you want to do a Congo red stain, as shown in this upper right image, you will, of course, find that beautiful apple green birefringence that is characteristic of amyloid. And of course, if you can make a cell block, you should stain it with calcitonin. It will be positive in almost all cases, although there are examples of calcitonin negative medullary thyroid carcinomas, and those drive us crazy. They're not common, thankfully, but they do occur. And of course, if you did a thyroglobulin, it would be negative. But TTF1 is positive in both follicular-derived neoplasms, like papillary thyroid carcinoma and Hürthle cell neoplasms, and it's also positive in medullary thyroid carcinoma. So you can't use TTF1 for that distinction. All right, well, we're talking about the differential diagnosis, and I think one of the biggest challenges here is distinguishing a medullary carcinoma from a Hürthle cell neoplasm. This arrow here is just pointing to a little blob of colloid here. And I think you'll agree that these look remarkably similar. Now, some of the traditional cytologic clues that we typically use are the chromatin texture. So if it has a salt and pepper chromatin texture, as seen on the right, you would favor medullary carcinoma, as opposed to the chromatin texture here on the left, which isn't nearly as classically neuroendocrine. Nucleoli typically are prominent in Hürthle cell neoplasms, at least focally, as seen here. They're not typically prominent in medullary carcinoma. Now, having said all that, there's exceptions to every rule. And ultimately, I would just recommend that you have a very low threshold for making a cell block. And if you have any doubt at all, do a thyroglobulin and a calcitonin. And in the majority of cases, that will clearly distinguish these two neoplasms. I promised to show you a medullary carcinoma that has more of a sarcomatoid or spindle-shaped appearance, and here is one. These cells are much more elongated with long tails of cytoplasm. You might think of something like a melanoma here, perhaps. in the differential diagnosis. I should tell you that some medullary carcinomas, not this one, but some of them can be pigmented. There is a pigmented variant of medullary thyroid carcinoma, so don't immediately assume that everything that's pigmented in the thyroid is a metastatic melanoma. Remember that some MTCs can be pigmented. Some of these cells in the spindled variants of medullary carcinoma are described as being comet-shaped, where the nucleus is at the head of the comet with a very long tail floating behind it. A very beautiful, apt description of some of these medullary thyroid carcinomas. And some of them can be somewhat pleomorphic in appearance. There is a so-called pleomorphic variant of a medullary carcinoma, and it might make you think about anaplastic carcinoma. They're not usually as pleomorphic as the standard anaplastic carcinoma, but they get pretty close. And again, another suggestion I would make to you is before you actually call something anaplastic carcinoma, just do a calcitonin. If it's positive, it's probably just an ugly variant of medullary carcinoma. Okay, we will move on because we have a little bit more to cover today. So here's a case of a tumor that is really not difficult to diagnose as malignant. This is an anaplastic thyroid carcinoma, and this is a fairly standard example of one. These are hugely pleomorphic. These are typically enormous cells. Look at this neutrophil here for size comparison, and look at the enormous and variable size of the malignant cells. Look at the chromatin texture. Look at how malignant this chromatin is. Big, big clumps of chromatin, uneven distribution of chromatin, clearly aneuploid, multinucleated. Here with the Romanowski stain, this one looks like a bizarre form of a megakaryocyte, if you will. Here for size comparison are some macrophages in the image on the right. Now, typically the problem with an anaplastic carcinoma is it's difficult morphologically to distinguish it from just a very poorly differentiated metastasis from an occult site elsewhere. We'll do immunostains if we have a good cell block. And the most useful stain here is PAX8, because most anaplastic thyroid carcinomas do stain for PAX8, but I think you all know that PAX8 can also stain other tumors like renal cell carcinoma and Mullerian cancers. So to a very large extent, clinical correlation is required for a definitive diagnosis of an anaplastic carcinoma, and typically we sign these out as malignant, favoring anaplastic carcinoma, but recommending clinical correlation to exclude a metastasis. And I think, as you all know, these tumors are invariably fatal and have a very rapid downhill course. Now, some anaplastic carcinomas have a predominantly sarcomatoid appearance. So the previous example was more epithelioid, if you will, because the cells were round or polygonal in shape, but here is an anaplastic carcinoma that is predominantly sarcomatoid in appearance. Again, pretty ugly, highly pleomorphic nuclei, and here in the cell block on the right, you'll see that there is very convincing necrosis, which is a common finding in anaplastic thyroid carcinomas. So again, this is our summary slide. I will just emphasize the differential diagnosis, including the metastasis. We talked about the pleomorphic variant of medullary carcinoma. And I want to add another entity here, which isn't very well described in the cytology literature, but is certainly described well in the histopathologic literature and is described in the WHO. And that's the follicular adenoma and the adenomatoid nodule with bizarre nuclei. Those bizarre nuclei can look pretty much like what you're seeing in anaplastic carcinoma. However, they typically still retain some degree of microfollicle architecture, and that might be the only clue that you're dealing with the follicular adenoma with bizarre nuclei rather than an anaplastic carcinoma. If the patient is young, if there's no necrosis, if there's microfollicular differentiation, hold back, be careful, don't call it anaplastic carcinoma, give it a differential diagnosis, and do some immunostains. If the thyroid globulin and the TGF-1 are positive, that almost excludes anaplastic carcinoma. These are positive in the follicular adenomas with bizarre nuclei, but negative in anaplastic carcinomas. Again, anaplastic carcinomas are only positive for a few immunostains. They're positive for keratins and usually positive for PAX8. All right, let's talk about something else here now. Take a look at this image and ask yourself what you think this might be. These cells are showing a fair amount of nuclear overlap, but there's a lot of cytoplasm here. These cells have a low nuclear cytoplasmic ratio. The cytoplasm is somewhat granular, so you might be thinking about a Hürthle cell neoplasm. That would be a very good guess, and probably without any other history, probably the best interpretation for this specimen would be suspicious for a Hürthle cell neoplasm. But let me point out a couple of things here that are a little bit unusual for a Hürthle cell neoplasm. First of all, the syncytial appearance of these cells. You don't see very good cell membranes here. Typically with a Hürthle cell neoplasm, you do see good good cytoplasmic edges. The other thing here is that this cytoplasm isn't really diffusely granular. It's a mixture of granules and vacuoles. It's partially vacuolated and partially granular. For those of you who see a good number of renal FNAs, I think you'll probably recognize this as a fairly typical appearance of a clear cell renal cell carcinoma. So this is a metastasis from a renal cell carcinoma. Now you may have that history, which would certainly help you. You may not. Sometimes the nephrectomy has happened quite a number of years ago. People have forgotten about it. People have assumed the patient is in remission and is cured and now presents with a thyroid nodule, which everybody thinks is a thyroid nodule, not related to this ancient history of renal cell carcinoma. You may have to dig very deep in the medical record to uncover that history. So these can be challenging if you don't have a good history. All right, so that's as much as I think we have time for the malignant category. Let's now turn and talk a little bit about Bethesda category 5, or suspicious for malignancy. So the Bethesda definition for this reads as follows: a strong suspicion of malignancy, but the findings are not sufficient for a conclusive diagnosis. Specimens that are suspicious for a follicular or Hürthle cell neoplasm are excluded from this category. The morphologic changes are of such a degree that you think a malignancy is more likely than not. And I'm showing you just one image here that would fulfill that criteria. And this is a highly cellular specimen that was mostly microfollicular in architecture, but where there was diffusely nuclear pallor, which was very suspicious for a follicular variant of papillary thyroid carcinoma. But there were no sonoma bodies. There were no papillae. There were very few, if any, pseudo-inclusions. So many of the other criteria that we talked about were absent in this particular case. And it's for cases like this that we will often use the suspicious for malignancy category, if only because of NIFT-P. Here's another example. Again, a mixture of both macrofollicular and microfollicular architecture with very prominent nuclear changes, mostly in the form of nuclear pallor and grooves, not very much in the way of nuclear membrane irregularity, and no pseudo-inclusions, no papillae, no sonoma bodies. So this is the kind of case that, again, you would call suspicious for PTC. And here's an example of what I mentioned before as the NIFT-P note. Now, you don't have to write this down because it is in the Bethesda Blue Book, but it reads as follows: the overall features are suggestive of a follicular variant of papillary carcinoma or NIFT-P. Definitive distinction between these entities is not possible on cytologic material. This is an optional note. You don't have to put it on the case, but we do actually use this rather frequently for cases like this in my laboratory. And this case I just showed you did in fact turn out to be an NIFT-P, and here is the histological resection. And here, by the way, in case you're curious, was the original ultrasound image, which certainly shows a well-circumscribed nodule. But the only way to be sure that there's no invasion is to do a lobectomy and sample the capsule very carefully. Now, here's another example of a case that would fit into the suspicious for malignancy category. Now, you may look at these cells and wonder, what is so suspicious about them? Well, let me point out a few features here. Yes, at first glance, they look so much like histiocytes. They have abundant cytoplasm. Much of it is vacuolated. But note that not all the cells have vacuolated cytoplasm. Some of the cytoplasm is actually fairly dense and almost squamoid. This is not characteristic of histiocytes, but even better, on this right-sided image, here are some cells that we can all recognize as macrophages or histiocytes. And clearly, this is a second population. These are much larger, much more atypical cells. Well, what are they? I mean, they don't really have classic features of papillary thyroid carcinoma. Well, let's make a cell block and do some immunostains. So first of all, let's make sure that they're not macrophages. So here's a macrophage marker. We do have some macrophages that are staining in the background for PU.1. But the atypical cells of interest are negative for this macrophage marker, and they're positive for PAX8, as shown here on the left, and they were also positive for TTF1 and thyroglobulin. So this is clearly a follicular-derived neoplasm. Now, if you've seen these cases before, you might recognize this as something that we call histiocytoid cells in papillary thyroid carcinoma. This is a cytologic term. This is not a WHO recognized variant of PTC. It's not even a histologic variant of or term used for papillary thyroid carcinoma, but it was introduced in the cytology literature to describe these very histiocytoid, atypical looking cells that often turn out to be papillary thyroid carcinomas. And this one histologically was just a classical papillary thyroid carcinoma. And if you look at histologic sections of classical PTCs, you will find the morphologic counterpart of these cells. They don't look especially like papillary thyroid carcinoma, even histologically, but in other areas you have classic features of PTC, which makes the histologic diagnosis so much easier. It's cases like this again that would fit nicely into the suspicious for malignancy category. I think very few people would feel comfortable calling a case like this, frankly, malignant. The management is either total thyroidectomy or lobectomy, and more people are now doing BRAF on cell block preparations, because if you have a very strong immunohistochemical reaction for BRAF V600E, that is not going to be a NIFT-P. It's not going to be a follicular variant of PTC, most likely, because the immunohistochemistry for BRAF in most hands is quite reliable and correlates nicely with a mutation detected by genetic means. We don't do that terribly often here in my own laboratory, but every now and then we do consider it, and we will do it occasionally when it might be critical clinically to get a more definitive diagnosis, if possible, and that's where a positive BRAF might be helpful. If the BRAF is positive, you can consider calling it just frankly malignant. And finally, we'll finish with a few words about the AUS or FLUS category. And of course, this is the most problematic of our 6 categories. It represents anywhere from 1 to 22% of all thyroid FNAs. And that tells you a lot already, that there's tremendous variability in how this category is used from one laboratory to another. I will confess some dirty laundry here. Our AUS rate in my laboratory is around 12%. We try as hard as we can to reduce that rate, but as you'll see in just a minute, we don't quite reach the benchmark that is recommended by the Bethesda system for this category. What is this category all about? Well, it's for cases that just don't fit neatly into the benign, the suspicious, or the malignant categories. We want to keep those other categories as pure as possible. So we do have this wastebasket category. And in the Bethesda system, it's defined as cells, whether they're follicular or parafollicular or lymphoid or other, with architectural or nuclear atypia that's not sufficient to be classified as suspicious or malignant, but more marked than can be ascribed confidently to benign changes. AUS and FLUS are synonyms. The laboratory should choose the term it prefers and use it exclusively for this category. I do think AUS is the more common choice, but there are some laboratories that use FLUS instead. I will say I think AUS is a more versatile name for this category because FLUS applies only to follicular lesions and can't be used if the cells are not clearly follicular in origin. So if they look more lymphoid or parafollicular or parathyroid. And this is the least reproducible of the 6 Bethesda categories. Not surprising there. So we had a question from somebody who attended last week's session. Thank you, RN, for your question. You asked, how do you distinguish AUS FLUS from suspicious for follicular neoplasm or follicular neoplasm? So my answer is, if you have a microfollicle predominant specimen, the distinction between AUS FLUS and SFN-FN is based on cellularity. To call it Bethesda 4 or SFN-FN, the sample must be at least moderately cellular. In other words, if a microfollicle predominant sample is sparsely cellular, you should use AUS FLUS for that case. And let me show you an example in just a few minutes. So a few more words about AUS or FLUS. Bethesda recommends limiting the use to 10% of thyroid FNAs. This is admittedly a somewhat arbitrary number. It was the result of expert consensus, but there's nothing terribly magical about this number. And I will say that a number of respected laboratories, I'm not sure how respected my laboratory is, but I know other laboratories that are very highly respected also struggle the way we do, keeping it down to 10%. Others have no trouble with it. And my hat is off to those other laboratories. The usual management is a repeat FNA plus or minus molecular testing. That certainly is the usual management in the United States. And we do recommend qualifiers. So we don't just call something AUS or FLUS, but then we go on to describe it. And we'll say that there's either cytologic atypia or architectural atypia or both. There is a Hürthle cell type of AUS FLUS that we're not going to have time to talk about very much today, not otherwise specified. And there is an atypical lymphoid cells category, which I illustrated last Wednesday. These qualifiers, at least as practiced in the United States today, are really for internal documentation purposes only. They really don't affect management. So whether it's cytologic atypia or architectural atypia or the Hürthle cell type of AUS FLUS, the management is generally going to be the same. But the qualifiers are useful because if you're looking at a repeat FNA, for example, on the same nodule, and you go back in your information system, it's nice to see what it was about the previous FNA that was AUS or FLUS that made it be called that particular category. To know, without having to go back and look at the slides, that it was cytologic or architectural or Hürthle cell changes that led to that diagnosis can be very useful in evaluating the repeat FNA. All right, another question from last week. Thank you, PK, for your question. You wanted to know, are we doing a FIRMA for every thyroid? So the answer is that at the Brigham and Hospital, our endocrinologists do not collect the AFIRMA sample upfront. In many laboratories, in many hospitals, in many endocrinology practices, the endocrinologist or the radiologist collect an AFIRMA sample for every thyroid FNA because they're not going to know whether the sample is going to turn out to be cytologically AUS or suspicious for follicular neoplasm. Our endocrinologists don't like doing that. They don't like sticking a lot of patients unnecessarily for the extra passes to collect the AFIRMA sample. So in our practice at least, they call the patient back to collect an affirma if the FNA turns out to be AUS or suspicious for follicular neoplasm. So let me show you a couple of examples. So here's a 53-year-old man with a 1.1 centimeter right lower pole thyroid nodule. And what I'm showing you here in this middle image is a nice benign macrofollicle fragment, evenly spaced thyroid follicular cells, round nuclei, and a good granular chromatin. But you will notice two nuclei here that are somewhat paler in color. Now, 95 or more % of the sample looked completely benign like this. And there was one other group of cells that had enlarged nuclei with some somewhat irregular nuclear borders and clearly finely textured chromatin. But again, remember that these two groups were the only two groups that looked like this, a tiny proportion of the entire specimen. Now, you wish you hadn't seen them because you would have just called this a benign follicular nodule. But there they are, and I think that this is a reasonable example of the kind of case that you would consider calling either AUS or FLUS, which is what we did here. So in our laboratory, we use AUS, so we called it atypia of undetermined significance, and then we use the qualifier focal cytologic atypia. Now, you're probably curious what this turned out to be. Well, this patient did have hyperparathyroidism, and they took out a parathyroid adenoma, but that's not really relevant here. The nodule that was biopsied turned out to be a 1.1 centimeter adenomatous nodule, as shown here. Clearly, mostly macrofollicular, but there was multifocal papillary thyroid microcarcinoma in the specimen. And here's one example of this embedded microcarcinoma on higher magnification. Here is a little bit of that adenomatous nodule, the normal thyroid follicular cells, and side by side, a beautiful histologic correlate to what we saw on the FNA. So clearly, they sampled just a tiny bit of this microcarcinoma as part of this adenomatous nodule. Here's an example of architectural atypia. This is a relatively young woman with a thyroid nodule. And what I'm showing you is a medium power magnification to make it clear that this was a sparsely cellular specimen. Now, in the background here, what do you see? Well, this is not colloid. You'll remember from our discussion earlier that this is just that granular precipitate seen better here, which is what you get when you lyse red blood cells using a liquid-based preparation. So this doesn't have very much colloid. It's sparsely cellular. It was clearly a very bloody specimen. You're not getting a very good look at it. It had a total, I counted them, 10 microfollicles on the entire slide. And every single one of them was what we would call a microfollicle, right? A small group with crowded, overlapping thyroid follicular cells. No features of papillary carcinoma. The chromatin is granular, so we're not concerned about a PTC here, but we are worried about it because it is mostly microfollicular. So there's clearly architectural atypia here, but you can't call it suspicious for follicular neoplasm because it doesn't meet the cellularity requirement. So again, in our laboratory, we call this atypia of undetermined significance with the qualifier of architectural atypia. Now, again, you might be curious what this turned out to be. This actually turned out to be a follicular thyroid carcinoma. It was encapsulated, but it was angioinvasive, and in this particular case, this patient had a good prognosis. The patient is still alive and well 8 years later. Here's an example of the focus of angioinvasion. This is not the usual follow-up of an AUS cytology. I think, as you all know, most AUSs turn out to be benign, but it's just a good reminder why we have this category and why we pay attention not just to cytologic atypia, but also to architectural atypia. Just a reminder again that not everything which is a small aggregate of follicular cells is a microfollicle. So here is an example of a benign follicular nodule that has some nice large macrofollicle fragments, but this is just a small fragment of a macrofollicle. If you were to cut a small corner off of this macrofollicle, it would look exactly like this. And the way you know that is the even spacing of these benign appearing follicular cells, the absence of any crowding or overlapping, not a microfollicle. Well, then again, what is a microfollicle? As we said before, these cells are typically crowded and overlapping. These are true microfollicles. This is not a microfollicle. And I keep reiterating this because I think it will help many of us limit the frequency with which we use the AUS category for suspicious for follicular neoplasm, certainly, and maybe even for AUS or FLUS. Well, that's really as much as I have time for today. I want to finish with this one slide. For those of you who are beginning your careers in cytology, I just want to say you're going to be introduced to a beautiful universe of cytomorphology of the thyroid. And there are so many things that we simply didn't have time for today. I'm showing you just a few examples here. You can see primary Hodgkin's disease of the thyroid. Here's a beautiful Reed-Sternberg cell. Here are the crazy convoluted dendritic cells of a primary Langerhans cell histiocytosis of the thyroid. Here's a granular cell tumor that looks for all the world like a Hürthle cell neoplasm. And here's an example of amyloid goiter. So I will stop there. Thank you very much, and I hope we have some time for questions.
Well, thank you very much, Dr. Cibas. That was amazing. That was a fabulous overview of these malignant categories and the very difficult Atypia category. And I can attest to the fact that Atypia is difficult in any reporting system, and I guess thyroid is no exception. It seems like we're getting a bunch of questions, and I'll try to ask them to you as much as I can, as much as time permits us to do that. So here's one question. Can you make a diagnosis of papillary carcinoma if you don't see any intranuclear inclusions? Say you see grooves, you see some papillary formations, but no matter how much hard you look, you don't see any sort of inclusions. What do you do with that?
Yeah, that's a very good question. I think before the era of NIFT-P, I would have said yes, yes, yes. You can make a diagnosis of PTC without intranuclear inclusions. I'm assuming that the case you're describing also lacks any papillae or Sonoma bodies. Otherwise, it would be easy. Of course, you could call it papillary if there's papillae or Sonoma bodies. I think you have to be careful nowadays because of NIFT-P. Now, if you have a predominantly microfollicular pattern, you should definitely be very careful. And I would not call that case malignant if I don't see any inclusions and it has a predominantly microfollicular pattern, because that's very characteristic of the follicular variant of PTC and NIFT-P for that matter. What do you do with a case that's mostly flat sheets, like I showed you in some of those examples of classic papillary carcinoma? You're probably on slightly stronger foothold, calling it malignant if you have a predominantly flat sheet appearance. However, I will tell you, I have seen some cases that have been called malignant that had a predominantly flat sheet appearance that didn't have inclusions, but turned out to be NIFT-Ps. So NIFT-Ps don't necessarily have to have a microfollicular pattern. So I sympathize with you. I think it's challenging, and it's not a bad thing to pull back and call it suspicious for PTC nowadays, given the redefinition of NIFT-P.
Mm-hmm. But for instance, when we say suspicious for PTC, would the surgeon go ahead and do the thyroidectomy?
That depends on other things besides the cytology diagnosis. So it will depend on the sonographic features of the entire thyroid gland. How big is the nodule? What does it look like? Does it have irregular contours? Are there other nodules that are suspicious in the rest of the thyroid? Are there enlarged lymph nodes in the neck? There are other factors that will play into the decision whether to do a lobectomy or a total thyroidectomy.
Okay. Now, along the lines of that, we have a question from one of our participants. The question is, can you have pseudo-inclusions that aren't PTC? And I think you went into it a little bit today and a little bit in the past week, but maybe you want to answer that question.
Yes, so there are two things I'll say. One is that there are things that are not pseudo-inclusions but can look like pseudo-inclusions, and typically they're smaller and they're white. They don't have the color and consistency of cytoplasm. Those are not pseudo-inclusions, and you should ignore those or not pay attention to them. Having said that, though, I have seen what look exactly like pseudo-inclusions in other conditions besides PTC. Now, I've mentioned a few of them today. I've mentioned medullary carcinoma and anaplastic carcinoma, but I also have seen one case that turned out to be a follicular adenoma that had one beautiful pseudo-inclusion. Now, that's very unusual. It's rare, very rare, that you'll see a follicular adenoma, and everything else about that case looked like a follicular patterned neoplasm without any nuclear features of PTC. But there it was, this beautiful inclusion. Otherwise, the nuclei looked round and dark, no grooves, nothing else. So it can happen. Unfortunately, there's exceptions to virtually every rule that I can give you.
Yes, that's right. Okay, so continuing with the NIFT-P question, with the introduction of NIFT-P, did your diagnostic rate for Bethesda 3 and 4 increase and Bethesda 5 and 6 decrease?
I don't know the answer to that because I haven't actually looked at that. I apologize, but I don't think I can honestly answer that question. I do want to say one more thing about the previous question, and that is that you can definitely see pseudo-inclusions in Hashimoto's thyroiditis. It's quite well described. So if the rest of your sample looks very much like Hashimoto's, don't jump on the diagnosis of PTC just because you see a pseudo-inclusion.
Sounds good. Okay. Another question is there an effective way to differentiate papillary thyroid carcinoma from HTT? I guess Hürthle cell lesions, they mean? Or Hashimoto's thyroiditis? I can't quite understand HTT.
Well, yeah, if we're talking about Hürthle cell tumors from papillary carcinoma, I think it's the nuclear features that you really have to pay attention to because the cytoplasm can look very similar, especially in the oncocytic variant. So look for inclusions, look for nuclear membrane irregularity. Nuclear grooves are not as useful because I think you can see nuclear grooves quite frequently in Hürthle cell neoplasms. Ultimately, it really does come down, I think, to the inclusions. And that's a situation where you might want to do a BRAF V600E immunostain. That might be helpful to point you in the direction of a PTC.
Mm-hmm. So now that you said BRAF V600E, there's a question on that. And the question is there utility of the BRAF V600E immunohistochemical stain in distinguishing ATCs from metastasis from different primary, where the positive is likely helpful, but negative is not helpful?
Yeah, I don't think so. At least I certainly haven't used it that way. We know that BRAF V600E immunohistochemistry can be positive in other tumors like melanomas and colon cancer. So I don't think that would be useful to distinguish a thyroid neoplasm from extrathyroid neoplasms.
Mm-hmm. Another question is, do you have experience with HBME1 in the Bethesda 3 categories when it is an atypia of unknown significance, or Bethesda, or in Bethesda 5? Essentially,
I will say we tried HBME1 a number of years ago in our lab and didn't honestly find it very useful in our hands. I know that there is some literature suggesting it can be very useful, and some laboratories do use it selectively. But I will admit that personally, I have not found it useful for those distinctions. Mm-hmm.
Another question is, now this is a good one, how do you distinguish papillae of the PTC from the papillae-like groups of the benign hyperplasia? Just from the architectural perspective, I guess.
Yeah, well, architecturally it's hard because they can look very similar. It really does finally come down to looking at the nuclei, and I will refer you to a paper that we published on this probably about 10 or 12 years ago on the cytology of papillary hyperplasia of the thyroid. So for more details, please take a look at that paper. But ultimately, it will come down to the nuclei. You can't really rely exclusively on the architecture there because you will be fooled. There are these entities, papillary hyperplasias, that can have papillae, and you'll see them very nicely on cell block preparations, for example, from thyroid FNAs.
Another question is the PTC variants. Do you mention these variants on your reports, or which ones?
That's a very good question. So it's not a requirement. There's no, I think, expectation, at least today, that we subtype a papillary thyroid carcinoma on a fine needle aspiration specimen. That might change, and it will make our lives so much more complicated if it does. I'm not sure I'm terribly in support of that right now, but having said that, if these features are very prominent, I have certainly been known to suggest the possibility of a tall cell variant or an oncocytic variant or diffuse sclerosing variant in a note, but I'm rather cautious in the way I do that. I don't say it's a tall cell variant. I just write a note that says some of the features raise the possibility of a tall cell variant. And of course, there are strict histologic criteria for how much of the tumor has to have tall cell features. And on a fine needle aspiration, we're not going to have access to the entire thyroid nodule to make that ultimate distinction.
And the management would not be very different in these variants, correct?
Well, that's a good question. Yes or no. I mean, sometimes in our tumor board, we do have endocrinologists who ask us in a borderline case where they're trying to make a decision in a patient between lobectomy and thyroidectomy, for example, whether the tumor had what they call high-grade features. So it does come up occasionally in clinical tumor boards, but it's not something that is routinely expected of a cytology.
Mm-hmm. This is a very nice question, too. Is the histiocytoid variant of PTC you showed, is this the same as what we call the cystic PTC?
Good question. So I think it's not, although the Bethesda Blue Book seems to imply that it is. I will tell you that it's something that I'm actively involved in researching right now with one of my fellows, and I'm hoping that we'll have a publication on this in the next year or so. So if you're willing to be patient, I'm hoping that we'll have a better answer for this, but it's not going to happen immediately. It'll probably be about a year from now.
That sounds good. We are patient. We can wait. To be continued on that one. Now, here's another good question, too. What is a microfollicle? How do you define how many cells there in a microfollicle?
Right, so I don't like using a number to define a microfollicle. For me, the size of the aggregate, it has no bearing on whether it's a microfollicle or not. Last Wednesday, I showed you a large aggregate of cells, that probably about 100 cells or more, that was a microfollicle, or at least a tissue fragment of multiple microfollicles. So I think it's futile to put a number on the size of a microfollicle. It's not really about the size. It's about the arrangement of the follicular cells. If it's a microfollicle, in my mind, if the cells are showing neoplastic growth, neoplastic behavior, they've lost that social distancing, which is required for normal follicular cell behavior. They're piling up, they're stratified, and the structure is uneven in shape. One thing I didn't mention is sometimes these microfollicles are fragmented, and you have a piece of a microfollicle, or at least you have uneven distribution of the nuclei around the perimeter of the microfollicle. To me, those are the feature. Now, having said that, they're usually small. Yes, they're usually less than, say, 30 cells or so. But personally, I don't find it terribly useful to talk about numbers like that. I think the important thing is to focus on the architecture.
Okay, so along the lines of that, architecture and cytology, this AUS FLUS business, when we look at these, you said use either the one, AUS, or the FLUS, and you said AUS is a little bit more versatile. But when you look at it, when you're describing it, AUS seems to describe a little bit more of the cytologic atypia, whereas when you talk about FLUS, it feels like more of an architecture. Like maybe there are some microfollicles just like you described, but there are not enough to call it suspicious. So why not, dare I say, keep these two categories separate? And just out of curiosity, were there any studies looking at the cytologic versus the architectural atypia and their follow-up of these?
Right, so that's a semantic question. Personally, I don't like using those two terms to mean two different things because that was not the intention of the Bethesda system. If you start using AUS and FLUS as separate categories, now you're expanding a 6-category system into a 7-category system. So the way the Bethesda system gets around it is by allowing you to use qualifiers. And that's why I talked about cytologic atypia and architectural atypia. To me, the word atypia does not imply nuclear atypia. To me, atypia can be either nuclear or architectural. And that's how the Bethesda system defines AUS as a more global definition of atypia. But again, we're talking semantics here. In terms of the second part of your question, are there some studies looking at the differences between cytologic and architectural atypia? Yes. There are quite a number of studies that suggest that the risk of malignancy for the cytologic atypia is higher than it is for the architectural atypia. I have to say I'm a little bit skeptical of those studies because I'm concerned that the things that people are calling architectural atypia are really just benign follicular nodules that have some microfollicles in them. Remember, you can have up to 50% microfollicles in a benign follicular nodule. And I just worry that some of the low malignancy risks that people get for the architectural atypia category might be the result of a dilution effect by a lot of things that really should just be called benign follicular nodules.
Interesting. There's a couple more questions. I'll ask a couple more questions and then in about 1:15 we'll stop. Let's see, the question here is, if a patient has a thyroid nodule and the cytology is negative, but this material is positive for BRAF by Afirma, does a lobectomy or thyroidectomy need to be done because of the BRAF mutation?
Oh gosh, wow, what a scenario. I have to say I have never encountered that, and I hope I never do. I guess the first question I would ask is why would somebody do Afirma on a benign thyroid FNA? We don't typically triage benign cytology for Afirma. There must have been something weird about that case that would make them send it off for Afirma. I would definitely want to go back and look at that, re-review that cytology. I'd be concerned that that might be a false negative, to be honest. I think that's as best an answer as I can give you.
But could it be a positive or false positive BRAF on the other side from the molecular perspective?
It could be. That is unusual. That rarely happens. But yes, that's a possibility. So I certainly, without further investigation, I would not recommend a thyroidectomy in that particular circumstance, if I'm understanding the scenario properly.
Another question is, if a smear shows predominantly macrofollicles, but there are rare inclusions, nuclear groups and scant colloid, which category is best, benign or AUS?
Oh gosh, well, it is very unusual to see really good inclusions in a benign follicular nodule. So I would worry about that case. Now one possibility is that those might be cyst lining cells, and I did show you an example of a benign follicular nodule last week that had focal cyst lining cells that had intranuclear inclusions. And so if those cells with the inclusions have the features of cyst lining cells, yes, if you're comfortable, you can call that benign, and we've certainly done that. But I'm not sure that that's the scenario you're describing. if you're describing pseudo-inclusions within macrofollicle sheets that don't have the features of cyst lining cells, that's a very strange scenario, and I'd be worried about that. I suppose I would call that AUS, or FLUS.
AUS, okay. All right, so the last question is going to be on QA issues. And I had this question as well as one of our participants, to keep the AUS FLUS rate low, to keep the Atypia rates. The AUS FLUS percentage seems to be governed by a large extent by the quality of the FNA sampling. Would you agree would be one question. And two is, how often do you look at the laboratory or the individual's Atypia rates? Another way to help out with this, yes.
Yes, no, so I do think that the quality of the preparations impact the frequency of AUS FLUS. Now, if something looks really uninterpretable, you should not call it AUS or FLUS. That should be non-diagnostic. So, be very careful not to use the AUS FLUS category for cases that are essentially uninterpretable because of clotting artifact or obscuring red blood cells or obscuring lubricant. However, if you do find groups that are visualizable and they have some nuclear features that raise the possibility of papillary thyroid carcinoma, but the sample is highly limited, yes, of course you should use AUS for that category. And if you have people who are obtaining the samples who are getting very bloody samples or are not very skilled at the procedure, you'll probably be faced with that situation more often than you should. And so some kind of feedback to your providers on technique would be very useful in that circumstance. The second part of the question is, yes, we do monitor our individual and our laboratory rates on a regular basis. We used to do it on an annual basis, and I used to send our cytopathologists a confidential memo that included their AUS rate as well as their ASCUS to SIL ratio and a few other quality control metrics. That was something that I would provide for them on an annual basis. We recently turned this into a cytopathology dashboard, which is now accessible by each of our pathologists whenever they feel like it. So they can log on to a dedicated website and they can look at their AUS rates or their ASCUS to SIL ratios for the past 3 months, or they can look at it by year. They can look at it longitudinally by the past 5 years, and this is updated on a regular basis, on a daily basis actually. So it's now in the form of a dashboard and not an annual confidential memo in our laboratory.
Wow, that is amazing. Well, that was great. Thank you so much for giving this lecture and answering all these questions. I really appreciate you being here with us. And for everyone else, thank you for participating and listening in and asking questions. And hope to see you all next week, where we have another webinar near and dear to me. It will be about how to critique a paper, and we have a very nice panel for you. So see you all next week.
Thank you very much. Thank you for attending. Have a great day.